There's also data such as the IMpower150 study that uses a combination of a platinum doublet with bevacizumab, so it's carboplatin, paclitaxel, bevacizumab, and then adds on an IO, atezolizumab. Now, we're trying to get away from just stacking more therapies on top of each other, but certainly bevacizumab was one of the pillars in which we built off of platinum-based regimens in the early 2000s, in case many of the fellows don't remember. This was New England Journal of Medicine stuff, and for years we could not find the benefit of an additional third therapy on top of a doublet, and bevacizumab was the first. There were trade-offs though, because obviously there were some side effects. It was a limited population, non-squamous, because of bleeding risks, but it finally gave us the first tool to be able to push out the survival, and it did by a little over 2 months, and that was a big deal back then. Now it's all changed, and the addition of the IO has certainly helped to this efficacy. There's some interesting subsets in this trial that we've discussed, we will discuss in the presentation, like the presence of liver metastases. Also, this is one of the few trials that allowed patients who had EGFR or ALK alterations and showed a benefit in this population. Normally, if somebody has a driver mutation, especially an EGFR mutation, you don't want to treat them with IO. That is a big no-no these days. But this is one of the studies that had about 100 patients in a subset that showed a benefit. So there is some intriguing results and something that perhaps the combination we can use in patients who have had a prior TKI, it stops working, and instead of just giving chemotherapy, a chemo doublet, we could actually feel safer giving an IO with the bevacizumab. So some intriguing data. It's not our standard frontline treatment, but it is there for that specific population.